couple of people staying to the last one. Yeah, it's a very busy day for me. It's my fourth activities of the day. So I will let Professor Xiong start the session. I hope I will not sleep during the session. All right. So Professor Xiong.
Thank you so much to stay to the last session here. And so the first speaker is Dr. Gao Dongwei. And Dr. Dong got his PhD from the National Taiwan University Institute of Clinical Medicine. And he's the attending physician in the Tri-Service General Hospital. And he's also the associate professor at the National Defense Medical Center. And today he's going to talk about body composition and biomarkers among different muscle health statuses. Results from the DYNASTY-TSGH Tri-Service General Hospital study. So let's welcome Dr. Dong.
Yes, thanks for Professor Xiong's introduction. Ladies and gentlemen, and welcome to this presentation. And I'm very appreciate your perseverance to keep to the final session. My topic is about the muscle health status, and focus on the body composition and some biomarkers. So, sarcopenia is a term released by the Iron Rosenberg since 1989. And it focused on the age-related decrease in muscle mass. I did not mention about the muscle function. And almost 2 decades later, the European Consensus of Working Group on Sarcopenia in Old People just released a consensus of sarcopenia, the diagnosis criteria, focus on the 3 parameters. One is grip strength, and the other one is gait speed, and the third one is the muscle mass. And define the cut point to represent the low grip strength or low gait speed or low muscle mass. And 4 years later, Asian Working Group of Sarcopenia also released a consensus. It's also focused on the same parameter, the grip strength and the gait speed and the muscle mass. But they defined definitely the cut point for the men and the women, and the gait speed lower than 0.8 meters per second. And they suggest to use the DEXA or BIA to measure the appendicular skeletal muscle mass. And in the beginning, from the 2010 and 2014, European Working Groups of Sarcopenia had defined a special term to describe the muscle health status. If older people just with muscle mass loss, it's called pre-sarcopenia. But older people have muscle mass loss accompanied with muscle strength decline, or physical performance impairment. It's called sarcopenia. And even old people have triple loss of these 3 parameters. It's called severe sarcopenia. But in clinical practice, you can find some people, they have low muscle strength or low physical performance, but they have reserve of their muscle mass. How could we define this phenomenon? Actually, in 2008, Dr. Clark and Dr. Bernini has released a special term of dynapenia. It's just focused on age-related loss of muscle strength, but reserve of muscle mass. And it also mentioned about that sarcopenia is not equal to dynapenia. In 2018, the European Working Group of Sarcopenia revised the consensus. They also awareness of the muscle strength is most important. So they provide flow chart to find out the candidate of sarcopenia. They use the SARC-F first to screen the possible candidate of sarcopenia. If the SARC-F is positive, they will perform the muscle strength, grip strength, or the chair stand test. If the muscle strength is declined, they will set up a specific term is a probable sarcopenia, which means low muscle strength is an indicator for probable sarcopenia in the future. And if they perform the muscle quantity using the DEXA, BI, or CT, or MRI, if it is positive, they have a muscle mass loss, they will confirm sarcopenia. And they perform the physical performance, and if it is positive, poor performance of physical performance, you will call severe sarcopenia. So this special term is probable sarcopenia, which means loss of muscle strength in older people. And also in the AWGS, they also revised for the second version. They also released a special term of possible sarcopenia. They also screen by the SARC-F or SARC-CAF, and then perform the muscle strength examination, such as hand grip strength or physical performance, 5 times a chair stand test. If it is positive, it's called possible sarcopenia. Or even either probable sarcopenia or possible sarcopenia, which means muscle strength loss. And then if the muscle strength loss first, they will perform a diagnosis to confirm the sarcopenia or severe sarcopenia by muscle mass measurement and the physical performance measurement. So from this flow chart, from these guidelines of sarcopenia, we can focus on 2 parameters of muscle health status. One is muscle mass, and the other one is muscle function, muscle strength or physical performance. So these 2 parameters could divide it into 4 categories of muscle health status. The first one is if old people have muscle function decline or muscle function positive, and then you will perform the muscle mass examination, muscle mass positive or muscle mass negative. So even older people with a positive muscle function and positive muscle mass, it's called robust. If older people have normal muscle function but loss of muscle mass, maybe called pre-sarcopenia from the consensus of Europe Working Group of Sarcopenia in 2010. If older people have low muscle function but they have reserved muscle mass, maybe you can call it possible sarcopenia because it's just the loss of muscle strength. And if old people have double loss in muscle function and muscle mass, it's called sarcopenia. So we can divide it into 4 categories to describe the muscle health status in older people. So in your study, I would like to answer a question because old people will transition from the robust to sarcopenia, from double positive on muscle mass and muscle function to the double loss to the loss of muscle mass and the muscle function. During this progression, either they will go to the DYNASTY pathway or pre-sarcopenia pathway. Either they will lose of muscle mass first or loss of muscle function first. And then eventually, perhaps they will go to the sarcopenia, the endpoint. If we set endpoint is sarcopenia. So I set up a long-term follow-up study. I call it DYNASTY and sarcopenia in Taipei City since 2015, just to want to observe the transitional trajectory from the robust to sarcopenia. So this method is study design is a longitudinal study since 2015, and we enroll the old people in the community age older than 65 years old. And we have annual health checkup in the Health Management Center. And this is conducted in the Tri-Service General Hospital. So we use the consensus cut point to measure the grip strength and gas speed and the muscle mass. And this is the schedule for measurement. On the baseline, we measure the BMI and body composition, waist circumference, and the fat component, and the grip strength, gas speed, and clinical events. And annually, every year, we follow up their body composition and muscle function, and to observe their clinical events, such as fall or hospitalization or ER visit or disability or something like that, metabolic syndrome, every year, and continue to follow up until now. And we have some exclusion of participants. If old people are under regular hemodialysis or congestive heart failure or the poor cognition, or if they have cancer under treatment, or if they experience a joint pain or chest pain during exercise, we'll exclude it. And we'll have a structural questionnaire to obtain health behavior, physical activity, and overall the health conditions, including physical activity. Because we are interested about body composition, so we focus on the obesity profile, including body mass index and the waist circumference, body fat mass, and body fat percentage. And especially we include the fat to muscle ratio, because we want to understand if the fat and muscle have some interaction to affect muscle strength or muscle mass. The aim of this study is just to understand the muscle health status, the four groups, what's the difference, or what's the prevalence and the distribution among old people. And the other one is to measure the body composition in different muscle status. And also the impact of muscle condition and on clinical events, just the fall and the metabolic syndrome and something else. We also examine the biomarkers related to the muscle and fat interaction. So first, I present the preliminary data. So this is the baseline from 2015. We enrolled about 765 participants in our center. You can find that all of them are almost a robust population. And the second one is the prevalence is dyspnea. And even higher, the prevalence is even higher than the sarcopenia. And the pre-sarcopenia is the last one in prevalence. And we can also focus on the special condition is their body composition, especially their BMI and the waist circumference and fat mass and body fat and the fat muscle ratio. In dyspnea group, they are the higher obesity profile among the four groups. And especially in the dyspnea group, they have a higher prevalence of metabolic syndrome and hypertension and some chronic disease. And the pre-sarcopenia is the reserve of muscle function, but they have muscle mass loss. They have the relative leanness compared to the four groups. And you can see the picture. We describe the obesity profile, such as the BMI and the waist circumference. You can see the dyspnea group has a higher obesity profile than the sarcopenia and pre-sarcopenia. And this is body fat percentage. body fat percentage and the subcutaneous fat is also show the highest prevalence in the dynapenia group, and the lowest one in the pre-sarcopenia group. And this is fat to muscle ratio. Fat to muscle ratio indicates obesity, another index to represent the obesity. It can also show that dynapenia group has a higher prevalence of fat to the muscle ratio. So we also examined the 4 risk among the 4 groups to test the clinical impact on different muscle health status. You can see we set the robust group as the reference, and the dynapenia group has a higher 4 risk than the other groups, than the sarcopenia groups. And the pre-sarcopenia groups has the lowest risk to 4. And we also examined the metabolic syndrome risk among the 4 groups. You can see that dynapenia groups, loss of muscle strength, they have a higher obesity profile, so they have a higher risk for metabolic syndrome than the other groups. And pre-sarcopenia, because they reserve their muscle function, but just the loss of their muscle mass. So they can reserve some function, and they may have the least metabolic syndrome risk among the 4 groups. So the brief summary in this presentation is dynapenia, loss of muscle strength, but reserve muscle mass, has more fat in body composition, and they have higher risk, higher fall risk in clinical events, and higher risk for metabolic syndrome than sarcopenia and pre-sarcopenia groups. So we think that muscle strength is more important than muscle mass in clinical events during aging process. So during aging process, we also encounter body composition change. When we are in young age, we have a high amount of muscle mass and high muscle function. And during aging process, when we're getting old, we have body composition change. Maybe we have a shrinkage of our muscle mass and loss of our muscle function, but our fat mass is increasing. So the different body composition means we have some interaction between muscle and fat. So in the previous study, they have summary some parameters to indicate muscle mass and adipose tissue. And the left one is normal status. Normal status means we have a good muscle mass and moderate adipose size. And this is the parameter, like marker like irisin and IL-6, IL-15. And the other one is adiponectin. This is a good marker to reserve a small amount of adipose tissue. And the right one is bad condition, which means the muscle fiber is shrinkage and the adipose side is getting large. So which means the biomarkers to interfere this condition is negative biomarkers such as leptin and myostatin and some interleukin-6, just like that. In our study, we just, because limited budget, we just performed some biomarker to examine the differences between these 4 groups. But almost all the biomarkers show a negative, non-significant association, just leptin. So I just show you the data about leptin. And leptin is different by gender. Female subject is higher than the male subject, maybe because we are modified by the sex hormone. And so we separate to describe these findings. The first is male groups, and we divided leptin into the quartile into the quartile. And you can see the quartile 4 is the higher leptin level, and the quartile 1 is the lowest leptin level. And you can see some parameters show significant differences, including BMI and waist circumference and SMI and gas speed. The higher leptin level, which shows a higher amount of BMI and the waist circumference and the rapid gas speed. And also in the obesity profile, you can see if people with a higher leptin, they will have a higher fat mass and fat muscle ratio, and they will have higher risk to have metabolic syndrome in the men groups. And also in the female groups, we also divide it into the quartiles to describe different parameters. It also has the same findings, including a high leptin level will increase the body mass index and the waist circumference and SMI, and they will have a rapid gas speed. And also in the obesity parameter, the higher leptin level will increase the body fat and the fat muscle ratio. And also have a higher leptin level will increase the risk of metabolic syndrome. We also examine the association between the leptin level and the muscle mass and the grip strength and the gas speed and some obesity parameters. It shows a positive association between leptin and the SMI and the waist circumference and the fat mass and body fat percentage, but negative association to the hand grip strength and the gas speed. So because leptin is associated with muscle mass and fat mass, and negative association to the hand grip strength and gas speed. So we collect it together to define the low muscle strength and reserve muscle mass. What's the difference between the association to the leptin level? So we define the logistic regression to observe if a higher leptin level will increase the risk of thalassemia or sarcopenia. You can see because leptin level is different in male and female, so we discuss it separately. So in first table, you can see the male subject. We compare the highest leptin level to compare to the lowest leptin level. You can see it shows a positive association. Also show a dose response effect. Compared to the lowest leptin level, the highest leptin level will increase the risk of thalassemia. The trend is significant. And in terms of sarcopenia show a reserve association, which means a higher leptin level will decrease the possibility of sarcopenia. It's so dose response reaction. And it also shows these findings in the female participants. So in this experimental summary, we can see the higher serum leptin level will increase the muscle mass and the fat mass, but will decrease the hand grip strength, gas speed in both genders. And leptin is maybe a status of good nutrition, so it will increase the risk of thalassemia in both genders. Maybe they will decrease the risk of sarcopenia because sarcopenia may be a status of low muscle mass, which means malnutrition. So in discussion, obesity and muscle function. So in the obesity history, if older people have a long history of obesity, they will have decreased hand grip strength. And in older people with a higher body fat percentage, they tend to have a loss of hand grip strength and work speed. And then the lower body fat percentage in the previous study. And also we find that in the previous study, along with the age increasing, we have intramuscular adipose tissue increasing. And the higher fat, which means you have the lower maximal torque of your leg. You have a lower fat, you will have a higher maximal torque of your leg force. So in addition, we introduced the fat-muscle ratio because in previous study also mentioned about this. And in Korea study, they found that fat-muscle ratio increasing, the hand grip strength will decrease. And also in California study, they also find the same results. So in our study, we demonstrated the fat-muscle ratio. And in thalassemia status, they loss of muscle function. But reserve muscle mass, they have fat muscle ratio increasing, but they have loss of their muscle strength. And in pre-sarcopenia, they are leanness, so they have a low ratio of fat muscle ratio, and they have increased grip strength and gas speed. So we can think that fat muscle ratio and muscle function is show a negative association. Maybe a fat will interfere with the muscle function. So in leptin, fat and muscle condition, in the previous study, leptin and fat and muscle, and the longitudinal study, leptin can increase the muscle, the trunk fat and their body fat. And also in the animal study, the leptin administration in mice, they can decrease the gradation, the protein degradation, and increase the muscle mass. So they can increase the muscle mass and the fat mass. But in muscle function, leptin is like a good nutrition status. So in previous study, they also show leptin concentration is positive associated with cholesterol or albumin, and negative associated with the malnutrition score. And leptin and muscle function also show a negative association in the previous study, especially in men. And leptin in skeletal muscle mass, skeletal muscle cell, they can increase the skeletal muscle cell and to increase the fatty acid oxidation. So they can to accumulate, if this pathway is blocked, they can accumulate deposit of fat in the muscle cell. Maybe it will interfere with their muscle function. So in previous study also showed that high level of leptin will in the obesity condition will increase the insulin resistance and the fatty acid oxidation will decrease, which means excessive lipid will accumulate in the skeletal muscle mass. So the muscle quality and the muscle strength will decrease. So the leptin level, which means hyperleptinemia, which means leptin resistance, because like the insulin resistance, your leptin in the obesity condition, they will have some resistance to blunt the signal transduction. So they will have decreased the fatty acid oxidation in muscle cell. So the intramuscular fat infiltration will increasing. So the muscle quality may be decreased. So in conclusion, in our study, we can see the prevalence and obesity and the fall risk and the metabolic syndrome, all of these parameters, thalassemia, loss of muscle strength, are worse than the sarcopenia groups. And during aging process, fat will again accompany with muscle loss, and this will interfere with muscle function, and it will make the muscle function decline. And leptin may be a status of a good nutrition status. So muscle mass and muscle function, muscle mass and fat mass will increase, and that may be decrease the muscle function because of leptin resistance. So that may be a status malnutrition. So maybe leptin maybe decrease the risk of sarcopenia and increase the risk of dyspnea. So I also want to acknowledge the National Taiwan University and Child Service General Hospital, and also the funding from the Ministry of Science and Technology. And I have to thank all the participants in this study. Okay, thank you very much.
Thank you, Dr. Gao. To save your question to the end of this session, and so the